السلام عليكم ورحمة الله وبركاته. معكم الدكتور هشام بن مسعود, استشاري بالطب العام واستشاري بالطب الطوارئ. Today we'll talk about a new topic. It's cough or difficult breathing in the IMCI program. And this topic is very important as one of the main complaints for the primary healthcare physicians under 5 years. Most of the cases arrive at as complaining of cough or difficult breathing. Have a different approach in different primary healthcare facilities, especially under 5 years. And there is many cases can be managed in the ambulatory care setting without need for referral to the hospital care. About this this complaint, we will start with this presentation for first of all, we will start with this topic, which is called assess, classify, and cough or difficult breathing. Our objective is assess and classify the sick child complaining of cough or difficult breathing, treat the child complaining of cough or difficult breathing, and counsel the mother about cough, difficult breathing, and give a follow-up care for cough and difficult breathing. As we all know, then, according to integrated management of childhood illness, we have 4 steps. First step is assess and classify the sick child. Second one, treat the child. The third one is counsel the mother, and fourth one, giving the follow-up care. Overall pictures of management of child complaining of cough or difficult breathing. As we all understand that when the caregivers, the mothers, bring her child to the primary healthcare facilities, we first of all, after the reception, the mother and the child go to the triage site where there will be some sort of questions to assess the severity of illness accordingly to manage either to the treatment rooms or to examination site to see by the direct physicians. So as we understand, after the reception, the child and the caregivers goes to the triage site where the GB nurse there or triage nurse will assess the child's severities if there's any general danger signs if present. And I just want to remind you about it. The child is not able to drink or breastfeed, or the child vomits everything, or the child has a convulsion or is convulsing now, or the child is lethargic or unconscious. So if there is one of the general danger signs, the child will be classified as very severe disease and should be referred to the treatment room where a quick complete assessment be done by the direct physicians and manage it accordingly. If the child is convulsing now, giving a diazepam, or if he's lethargic or unconscious, we'll give him a dextrose for checking low blood sugars. And as I mentioned, that give very referral treatment immediately and keeping the child, refer him urgently to the hospital. If the child didn't have any general danger signs, we assess according to the specific complaints. For this child who complaining according to the mother cough or difficult breathing, we should assess for look and listen for stridors. Stridor is a harsh sound, noisy sound listened at the time when the child breathes in. The stridor happens when there is a swelling in the larynx or the trachea or the glottis. The swelling interferes with the air entry or to the lungs and can be life-threatening conditions, and even cause to complete blockage of the upper airway and leading to death. Striders when the child is calm is considered as a specific danger signs and should be the child referred immediately to the treatment home. You should, as a healthcare workers, can differentiate between striders and other harsh noises like wheeze, which is the musical sounds can be listened at the time for child's breathe out, or it can be there is a harsh noises when the child have a blocked nose, and usually this sound is listened in the child's breathe in and out all the time. We should, when we thinking about striders, the child should be calm. If there is a child is irritable or crying, and you listen to the striders, most of the times, sometimes it's not considered as a specific danger sign. So I just want to remind you again, after the child is sick, goes to reception and then to triage corner, and after assessing general danger signs, if there is no general danger signs, we assess for specific danger signs according to specific complaint in the triage corners. And after that, if the child have one of both, general or specific, goes to the treatment room, and from that we manage accordingly and assess him quickly and to the hospital. Otherwise, if the child didn't have any general or specific danger signs, we can the child refer to the waiting area until seen by the physicians. As I mentioned, the categories of any general danger sign of stridor income child, we classify him as severe pneumonia or very severe disease. Then, if the child, as I mentioned, didn't have any general or specific danger signs, we can the child waiting in the waiting area until seen by the direct physicians, and after that we manage it accordingly. Either we can discharge him as a home care or refer him in the hospital outpatient clinics, or either in the emergency department. So in this specific complaints, we have two situations. If the child doesn't have any general or specific danger signs, either the child have chest drawing or fast breathing, and one of both or both together is we classify the child as having pneumonia, or the child will be if the child doesn't have either one, and there is no any general or specific danger signs, we classify as in cough or cold. So this is an overview of assessment of the child and how to manage it accordingly to the brain health care. Now we go to the section 1, which is called assess and classify the sick child. When we go into assess and classify the sick child for cough or difficult breathing, first of all, at the time of assessment, we should ask the mother about, does the child have a cough or difficult breathing? So if the child have difficult breathing, is unusual pattern of breathing. So what is the difficult breathing? It's any unusual pattern of breathing, and it could be fast, could be noisy, could be interrupted, and all of these as a concern from the caregivers is classified as difficult breathing. If the mothers or the caregivers answers no, we should look to the other complaints. If the mother says yes, we have other questions, detailed questions for the cough, and we should next question should be asked for how long. The child who has had a cough or difficult breathing for more than 14 days, consider it has a chronic cough. And there is another differential diagnosis for the chronic cough. Maybe a sign of foreign bodies in the respiratory tract, or tuberculosis, or an asthma, or any other problems. So as I mentioned, that the child could have an acute cough or chronic cough, and the cutoff point for acute and chronic cough is the durations. If the duration is more than 14 days, we consider it as a chronic cough, and there is another differential diagnosis, as I mentioned before. And these differential diagnoses could be foreign bodies or asthma or tuberculosis. And all of these, we need to refer the patient to the secondary levels for excluding them or including them. And if your primary healthcare facilities can manage for these differential diagnosis, or your competency is enough to manage, we can. Otherwise, we should refer him to the hospitals or secondary levels. For acute cough, in under 5 years, we then counting the respiratory rate, and by counting the breathing for 1 minute. And there is two categories for a cutoff point in different age groups. For the age group between 2 months until 12 months, the cutoff point we consider it as fast breathing is 50 breaths per minute or more. If the age group is between 1 year until 5 years, the cutoff point is considered 14 breaths per minute or more. So anyone 50 breaths per minute or 40 breaths per minute according to specific age group, if it's higher than it at the time of counting the respiratory rate for the child, we consider it as a fast breathing. So our question is, the child has a fast breathing, we should only counting for the breathing, and after that we can recognize and identify the child is having fast breathing. But be careful when you want to count the breathing. The child should be calm and not crying, and or even frightening or angry. And the best time, if it's visible, when the child is sleeping, is very, and this is the best time to count respiratory. Look to the child for system drawing. Usually, the system drawing, it doesn't mean what we know as physicians as intercostal recessions or subcostal recessions. It's only the chest cage, the lower part of the chest cage is going in when the child's breathing. And this one is considered as one of the signs of pneumonia. And usually the fast breathing and chest drawing is one of the pathological responses of the child coping with hypoxia and consultation of lungs. So if you find fast breathing or chest drawing, we should consider that the child has pneumonia. Usually the chest wall at the time of normal breathing, the whole chest wall is breathed out when the child is breathing. Again, at the time of the clinic, you should assess again for the specific danger signs and assessing the stridor again in your site in the clinics. And if there is any stridor when the child is calm, we consider the child has a very severe disease of severe pneumonia. I will skip it. So at summary, we in your clinic, you should ask if the child has cough or difficulty breathing. If yes, you should ask for how long either the cough or difficult breathing. If it's more than the cough for more than 14 days, we should have another differential diagnosis. If it's less, we consider it as acute cough, and then we should look for fast breathing, chest drawing, and stridors in calm child and wheeze. Any one of these, if it's found, we should manage accordingly. And just want to remind you about the cutoff point for the fast breathing for specific age group. As I mentioned before, that between the age of 2 months until the 12 months, the cutoff point was 15 breaths per minute or more. And if we're talking about the age group between 1 and 5 years, the cutoff point is 40 breaths per more, considered as a fast breathing. So you have two, and just want to remind you about chest drawing is the child lower part of the chest cage is going in when the child is breathed in. Stridors is the harsh sound listened when the child breathes in, and the wheeze is the musical sounds that listen when the child breathes out. So all of these signs we assessed, and then we should go to the classifying the cough or difficult breathing. And this classification, just want to remind you again, it's severe pneumonia or very severe disease, or we classify it as pneumonia or cough and cold. So as you see here, there's different colors. The red one is considered as a severe case and need an urgent intervention treatment, should be referred to the treatment at home and then to urgently to the hospitals. And pneumonia is considered as an also a considerable disease and need an outpatient management. A cough and cold, usually, or just to reassure the child and give him some home medications. So just again, I want to remind you that how to this classification be classified. If for severe pneumonia or very severe disease, if any general danger signs plus or stridors in calm child be considered as severe pneumonia or very severe disease. About pneumonia, we classified if the child had a chest drawing or fast breathing. About cough or cold, we classified if there is no sign of pneumonia or signs of very severe disease. This is another one, just a reminding. And then we go to the treatment. The treatment here for cough and difficult breathing. For severe pneumonia, we just give the first dose of appropriate antibiotic and then refer urgently to the hospital. When in pneumonia, we just give an oral amoxicillin for 5 days. If wheezing or disappear after a rapid acting bronchodilator, give an inhaled bronchodilator for 5 days. And soothing the throat and relievers the cough with safe remedies. If we cough for more than 14 days or recurrent wheeze, refer for possible asthma, foreign bodies, and TB assessment. Advise the mother when to return immediately and follow up in 3 days. So the fixed follow-up is in 3 days for pneumonia. About cough or cold, if a wheeze, we just, even if disappeared after rapid acting bronchodilator, give inhaled bronchodilator for 5 days. Soothing the throat and relieving cough with the safe remedies. And if cough for more than 14 days or recurrent wheeze, refer for possible asthma, foreign bodies, and or TB assessment. Advise mothers when to return immediately. And follow up in 5 days, if not improvement. So in cough or cold, there is no fixed follow-up, but just having another, if not improved. If not improved, you can follow up after 5 days. Otherwise, there's no fixed follow-up. About any medications, when you want to give it to the patient, you should instruct the mothers about the drugs at home. And this one, we should consider them very carefully. The instructions should have determined the appropriate drugs and the dosage for the child age and weight, and tell the mother the reason for giving these medications for the child, demonstrate how to use this medication and measuring the doses, and watch them practicing measuring the dose by herself. Ask the mother to give the first dose to her child at your clinic explain carefully how to give the drugs and the label and package the drug. If more than one drug will be given, collect, count the package with each drug separately, and explain that the tablet and syrup must be used to finish the course of treatment, even if the child gets better. Check the mother's understanding before she leaves the clinic. All of these instructions very important to be followed, and it's helpful for improvement, quality of care, and understanding of the child, mother's child, or the caregivers. In addition to that, helping for adherence or concordance of the caregivers to your instructions. About the antibiotic treatment, it's given for a pneumonia, and it's an oral amoxicillin. Oral amoxicillin is a recommended first-line drug of choice in treatment of pneumonia due to its efficacy and increasingly high resistance to coccidioxazole. About the doses, there is a 3 recommended doses according to the age group. Before we go into this age group, we just want to know about the syrup. Syrup concentration in our country is 250 milligram per 5 ml, and the frequency of the medication we should giving in the 5 days duration is twice daily. So now we're going to the recommended doses about in a specific age group. If the age group between 2 months until 12 months and the body weight between 4 to 10 kg, we give 5 ml. If the age group between 12 to 3 years, between 1 to 3 years, and the body weight between 10 and 14 kilogram, we give 10 ml. If the age group between 3 and 5 years and body weight between 14 and 19 kilo, we just give 15 ml twice daily for 5 days. So about the bronchodilator treatment, we give inhaled salbutamol for wheeze, and only use spacer. The spacer is a way of delivering the bronchodilator drugs effectively into the lungs. No child under 5 years should be given an inhaled without the spacers. Spacer works as well as a nebulizer if correctly used. So we don't need to give nebulizers every time. We just can give an inhaled salbutamol with spacers. For salbutamol metered doses inhalers for children under 5, we give 100 microgram per puffs and give 2 puffs. Repeated for up to 3 times every 15 minutes before classifying as pneumonia, especially if the child has fast beating disease. And if a spacer is being used for the first time, it should be primed by 4 to 5 extra puffs for the inhaler. Children with wheeze should continue getting 2 puffs of inhaled bronchodilator 2 times daily for 5 days. In a setting where the inhaler is not available, we can use an oral salbutamol maybe as a second choice. But most of the time, we should avoid it because of the side effects of the medications. You will learn how to teach the mother to give the inhaled salbutamol for home treatment in training units. Teaching the mother to give treatment at home. Most of the time, we do that by the GP nurse. We counsel her to train the caregivers how to use an inhaler salbutamol with spacers for children under 5, and they are assured that they understanding the approach and do it correctly before going at home. So to use an inhaler with spacers, we remove the inhaled caps and then shake the inhaler well and then insert a mouthpiece of the inhalers through the hole in the bottle or plastic cup. The child should put the opening of the bottle into his mouth and breathe in and out through the mouth. The carer then press down the inhaler and spray it into the bottle while the child continues to breathe normally, and waiting for 3 to 4 breaths and repeat for total of 5 sprays. For younger children, place the cap over the child's mouth and use the spacer in the same way. About the soothing of the throat. Soothing the throat, relieving the cough with safe remedies. It's a good practice to do it at home. And if the child is under 5 years, under 6 months, we can give only breast milk for breast infants. Usually, if you think about it carefully, when you have a fast breathing or cough, you have some sort of dehydrations, and the air goes in and out frequently from the mouth, and that leading to harshness and dryness and crackles and that making it painful and breathing. So giving fluids that can soothe the throat, and by this way we are reducing these crackles with time. Otherwise, that's why we recommend under 6 months of age just giving frequent breast milk, as we recommended for this specific age group. About the age group between 1 year to 5 years, we can give lemon and honeys. Just we mix juice of 1 lemon with 1 equal amount of honeys and twice amount of clear water, and give it the child with a teaspoon 3 to 4 times a day. And we can using either Zater for the age group, which is between 6 months and 1 year, for a cough reliever. And we should take it seriously about anti-cough syrups like antihistamines or codeine medications, that all of these have not proven to have any efficacy and have more harmful side effects, like constipations, dryness, drowsiness, and all of this can change the pathology or have a complication to the children. So we don't recommend either antihistaminic medication or medications that contain codeine as a anti-cough syrups. Just want to remind you again about the follow-up care for pneumonia. As we mentioned that before, that in pneumonia, we have a fixed follow-up after 3 years, after 3 days. And we check the child for general, when the child arrives, we check the child for general danger signs by triage nurse. And then after that, we check the child if they have any other complaint than the previous one. And we should, if they have a new complaint, with the assistant classifier, treat the new complaint. Assist and the child for a cough or difficult breathing. For specific that complaint, we ask if the breathing is slower or the chest and drawing disappear, or there is no chest and drawing, or either the chest and drawing coming. Is there less fever and is eating well or eating better? All of these questions very important to assess his improvement for this complaint. So we have 2 scenarios, 2 possibilities. Either the child have a breathing slower, no chest and drawing, less fever, eating better. And like that, we just only recommend completing for the medications until finishing 5 days of antibiotic, and raising the caregivers about their actions. And we have another possibilities that the child will have any general danger signs or chest and drawing, or there is a striders. We just only refer appropriately the child urgently to the hospital. So when you're talking about cough or cold, as I mentioned before, there is no any specific follow-up. We just there is no follow-up care for cough or cold. But if the child have any worsening situations, so we have follow-up after 5 days. If not improved, we just follow up after 5 days. As I mentioned before, maybe the changing the child's in the follow-up from care from acute cough to chronic cough, and then after that we have another differential diagnosis for cough. As I mentioned, maybe the child will have looking for foreign bodies or asthma, or assessing for TB possibilities. About counseling the child mother in pneumonia or cough and cold, we have what we call the safety net, and that means when to return immediately. We should advise the mother when to return immediately. And we have two possible scenarios. Either we classify the child as pneumonia or cough or cold. So if the child assesses as a cough or cold, we tell her that if the child has a fast breathing or difficult breathing, should be returned immediately. That means the child changing his or her classification from cough or cold to pneumonia. And if the child has pneumonia, we advise the mothers or caregivers to return immediately if the child have any of general danger signs or struggle in calm child. So either one, that means the child's worsening situation changing from pneumonia to severe pneumonia or worse disease. About the home care, we advise the mothers to increase the fluid during illnesses and breast milk more frequently and for longer duration. So we are insisting on frequency and duration to be more and in both. If the child is not on pure breast milk, we can and have a breast milk substitute. We increase the amount of the milk, and we give soups, rice, water, Viagra drinks, or clear water. All of these fluids helping to reduce the insensible loss that happen because of the fast breathing. About the promotion advocacy, especially should be given appropriately at the time. For example, if we classify him cough or cold and there is a near time for vaccination, we advise the mother for the next child visits and immunization if proper. So we concern more about the cough ethics at home, and hand hygienes. All of these is very important, and especially nowadays we should concern about corona, and we think that hand hygiene, cough ethics, and good ventilations at home is very important to reduce the risk of transmission. Thank you for participation. I'm welcoming you again for this presentation. I hope all of you understand the content and enjoy it, and we'll have a very soon meeting together. I hope you enjoyed. Thank you, and bye-bye.